Okay, we start the recording. So let's go briefly over emergency radiology altogether, hyper-emergency radiology, more better to say. Let's start with the very basics. When you are working by yourself as an emergency physician, as a ward physician in the department at late night, some patients, the parents bring you a 4-day-old very small baby with cough and fever. Okay, when you measure the fever, it is 39 degrees Celsius, and you listen to the lungs. You hear crepitations on the left side. Okay, so you decide to order a chest X-ray to this small baby. What should you include in the order? Do you have anything in your mind? What should you include in a typical radiology examination order? Because you will be ordering these exams, right? What should you include?
Chest tomography, I think.
Chest X-ray. We are ordering a chest X-ray, Emre.
Yes.
Not tomography. But what should we write in a radiology examination order?
The patient's situation.
Situation, yes. Patient's name first, okay, and defining patient information also as well. Patient's information, patient's condition, right? Patient's condition. Also, what do you think of this patient? Like, what are you suspecting? Like, what do you want to see in the examination? That's also very important. What is your pre-diagnosis? Because you have examined the patient, the radiologists have no idea about the patient. Will never have the idea. Okay, so these are like abroad, especially in the developed countries, the orders are much more organized. Like in Turkey, it's usually a click of a button, and the places where you need to write the patient information are usually filled with 3 simple dots. Like that happens a lot, which is very wrong actually. So in a typical radiology examination order, you have to enter patient details, but not only patient name, also at least one other defining factor in patient, like patient birth date, for example, patient identity number, or because in the hospitals usually you stick the sticker which contains like all of the patient information, which is enough. But if you're ordering it with, for example, on a paper, writing the name, like names can easily be missing. They can easily mess up, right? So you need to enter date also. That's also important. Also, background medical information. Does the patient have any medical disease, like cardiac disease, diabetes, for example, or any contraindications? Also, you need to answer the clinical question to be answered as well. Like, what are you looking for? Pneumonia, question mark, something like that. Pneumothorax, question mark, okay? Cardiomegaly, question mark, things like that. And of course, you have to enter what you want, chest X-ray or chest CT, like what is your choice of modality. And in the end, you have to sign and put your own identity information as well. Yani adı, soyadı, TC, doğum tarihi, varsa barkodunu yapıştırıyorsunuz. Barkodu clinical information is cough and fever, and history is okay, this patient has cystic fibrosis in the family, let's say, okay. And what is your pre-diagnosis? And you order the modality, you write the modality, what the kind of an examination you want. Kaşe, imza, pıt, gönder. Who orders radiological examinations in Turkey? Physicians order radiological examinations, not anybody else. This can be different in other countries. Okay, in some countries also nurses can order radiological examinations as well. So you order the chest X-ray, and they come back to you in 10 minutes with a chest X-ray in hand. Does anybody want to have a word about this chest X-ray?
Hocam kardiyomegali var gibi.
Kardiyomegali var, somebody said. What else? There was something else. Somebody said
The lung,
lungs?
like a bit grayish. So
Grayish on the which side?
on the
Where?
right side, on the right side, so the patient's left side.
Okay, good, very good. By the way, if you take your mouse to the very top of the screen, and you can add annotations, and everybody can write. By the way, if you are trying to point an area, you can do it with Zoom. So the patient's left lung is actually brighter than the right lung, right? Generally, like this area is much brighter than this area. This is very good, doctor. Very good that you talk about this. Also, I'm seeing this area, right? What is this? There is a focal density on one of the lungs, on the top of the lungs also. These are two things I mentioned. One of the doctors said cardiomegaly. This is normal for newborn baby. Newborn babies also, their hearts look like this. Also, the mediastinum is usually quite white. Like this is quite wide for a grown-up, but this is normal for children. Usually children have thymus as big as this. So these are within normal limits. But there is some abnormality, right? We're seeing the abnormality right away. One on the right lung and the other on the left lung.
Can we see pneumonia, hocam?
Or pre-diagnosis can be what? Pneumonia, good. What else? Can you think of anything else, which is actually quite rare? One thing I can consider is that, like, I'm seeing some asymmetry, right? That's true. There is something brighter on the left side, true that. And the right side is more lucent, darker. So it can be some left side pneumonia, but also it can be a pathology which is increasing the inflation of this side as well. So both is possible. When you're seeing an asymmetry, there's this. The problem can be there, or can be on the other side as well. Okay. I think that's pretty much it. So we are seeing something on the right upper part. Also, the left lung is hyperinflated. Heart is normal, as we have said. Another patient with the same complaints, with fever and cough, have presented to you, but this time the patient is 45-year-old male, which has a kidney transplant. Okay, so the patient admits to the emergency department. You want to see a chest X-ray first. You order chest X-ray, and it comes like this. Does anybody want to have a word about it?
Is there B or A? I don't know what curly lines. This.
Where? You mean curly? You said?
Yeah. I'm not sure about it, but I mean in the peripheral of the lung, the lateral.
Which lung?
The left lung. There is like white lines invading the lung.
You mean these small lines?
So the right.
The right lung.
Left,
this area, right? This area.
Yeah, and above
I'm seeing a cloud-like opacity, like cloud-like density on right upper lung again. Also on this side as well, maybe there is some faint densities. Were you mentioning somewhere else, doctor?
I think there are nodules in the right lung.
Excuse me?
I think there are nodules in the right lung.
This?
Yeah.
It's possible, but it's most likely a pulmonary artery which is making a right turn and which is coming at you. So when the pulmonary artery is pointed at you, it has a much prominent density. So around the hilus, like small areas which are close to the hilus, there we are very commonly seeing nodular densities, which are actually blood vessels. Like when the blood vessel is going like this, you can see it like when it's going perpendicular to the screen. Yeah, but when it's coming right at you, it makes a nodular density. I have noted faint densities here, some faint densities here as well. I'm seeing a little bit of lines which is a little bit abnormal, especially in this periphery of the lungs.
Like
There is no free fluid inside the chest X-ray, like there is no fluid. Costopharyngeal sinuses are empty. What about the heart? What do you think about the heart? For measuring the heart diameter, I'm measuring the inner diameter of the thorax and the diameter of the heart. So if this is bigger than 0.5, then the patient has cardiomegaly, right? So I think this is, I'm using my fingers when I'm measuring this. So I will be doing the same thing again. Yeah, it's actually bigger than half of the half of the thorax diameter. So the heart is also a little bit enlarged. By the way, I'm seeing metallic densities here, right? Do you know what is this? This is metallic sutures, which is suturing of the sternum. They do this after cardiac bypass operations. So the patient has a bypass operation, we can see it from here, and the heart is bigger, probably some cardiac problems it has. But rather than that, I mean, the situation on the lungs is more important. So the patient is a kidney transplant. You order, you ask this to the pulmonologist, and pulmonologist orders a CT scan, and we are seeing a CT of the same patient now. What are we seeing? On the left lung, I'm seeing pretty much a normal lung, maybe a little bit small nodular densities here and here. Also here, maybe some small densities. These are pulmonary vessels. But on the right side, on the upper part, this is the part that we have seen on the chest X-ray, right? I'm seeing densities like this. I'm seeing linear densities. What can be our pre-diagnosis for this patient? I'm seeing some abnormality on only some part of the lung, right? So it should be like the disease we are talking about should be some focal infiltration area. What can be?
pneumonia.
Pneumonia.
Okay.
Pneumonia in a kidney transplant, the patient is probably getting immunosuppressants, right? So yeah, let's move on. Okay, we are seeing a CT scan. I'm taking the lead now. I can give you the link from the chat window, and we can do this interactive as well. Okay, I'm having a hard time understanding this. So the patient has renal transplant. It has fever for 2 weeks. Okay. Systolic blood pressure. Okay. Also, the patient has also hypertension. I'm going to the next slide. Hoping that it can work. Okay. Okay, this is the chest X-ray we have been, and the small image that this is the whole CT scan of the small image. So in some areas, I'm seeing the air density is totally obliterated, right? It looks like a soft tissue. On the other areas, it's pretty much like lines, and there is some hazy structures as well, like the density, like the general density. Except from the lines, the general density is also increasing asymmetrically, right? I'm seeing some nodular densities as well, and the infiltrations are on both sides, but patchy in patchy manner. I mean, like not all the parenchyma is infiltrated. I also take a note at this as well, and that's pretty much it. I can say there is no pneumothorax, there is no free fluid in thoracic cavities. So let's move on. All right, this patient has pneumonia, by the way. So we are seeing multiple small ill-defined nodules in both lungs, some nodular densities as we have talked about. We are seeing some tree in bud appearance, which is a little bit detailed. I'm not going to ask you. I'm not seeing any mediastinal abnormality. The heart is a little bit enlarged, but mediastinum was quite nice. There is no pleural abnormality. So this is an infective process. This is a typical atypical pneumonia, by the way, a typical case of atypical pneumonia. Usually the pneumonias are in community acquired pneumonias. Usually they look like this. They put only one segment or lobe of the lung, that we call them lobar pneumonia. I am sure that you have heard about this before. Sometimes they are also patchy infiltrations in ground glass densities, like hazy, cloudy appearances. Does this look familiar to anybody in any manner? Do you remember something when you see this?
COVID.
Yeah, right. Typical COVID. It looks like really. It's some hazy areas which is on the periphery of the lungs, right? And sometimes pneumonia can present as this case we have seen. So in this patient, the pneumonia cause was cytomegalovirus. But mostly, if I seen something like this, I would think of other infections like mycobacteria or something. And in immunosuppressed patients also, pneumocystis pneumonia is also very, very common, especially in AIDS patients. It's a long story. Like now, AIDS patients, they almost never occur. Like HIV positive patients never go into AIDS now because of the good therapy. But it was a big thing before. So as we are seeing, we are thinking of the patient as mycobacterium. Even they have asked me about this, but the diagnosis was cytomegalovirus. So it's not always possible to look at the image and see and make the correct, like nail the diagnosis, but we can have an idea about the general. We can have an idea with looking at the general infiltration pattern. We will come to this on chest X-ray. This was just a small entry of that. So as I did before in the very first lecture, I will do this again. I will check the normal CT scan, and I will go over the organs. Let's try our chance again. Hope it works now. Okay. I'm having a little hard time going into looking the chat window. So please open the microphone and say it, okay? Okay, I'm starting from the top. We did this before. Let's quickly do it again. I'm seeing the trachea. I'm seeing the thyroid gland, right? These two dots are carotid arteries. They will originate, I'm going down, they will originate from the arcus aorta, right? This carotid originates from somewhere else, but anyway. I'm seeing the subclavians, which are going to the arms. I'm going down, I'm following the trachea. I started seeing the arcus aorta, right? Which will take a sharp turn on the upper thorax. And as I go down, I started seeing the pulmonary trunks. The main pulmonary trunks is this, and it divides into two, right and left. So there is a reverse Y or like X appearance, very typical for pulmonary arteries. Please remember. As I'm going down, I'm seeing the ascending aorta, and I'm seeing the descending aorta. The descending aorta is going to go all the way down to iliac arteries, right? We have talked about it. When I go down, I started seeing the heart. I saw the right chambers and I saw the left chambers. And I'm seeing the small pulmonary, like lobar and the segmental pulmonary vessels as well. And I go down more. I'm seeing the liver and the spleen and the stomach. If I go down a little bit, I'm seeing the pancreas and afterwards the kidneys. And this is usually the end of a typical thorax examination. Because I'm trying to see the whole lung, I'm including some of the abdomen as well, because it's going down on the backside, right? So why I'm not seeing the lung here? Because the densities are so low, it looks completely dark, because actually none of the screens can show all of the colors in a CT scan, and your eyes cannot distinguish both at the same time. So I'm using windows. I'm looking at the soft tissue window now, so I need to change the window to see the lung areas. When I switch to lung areas, the soft tissues look extremely bright, so it is hard to differentiate now between them. But the lungs look obviously better. Okay, this is a typical lung. Also, how many lobes does the left side have or the right side have? Do you remember the lobe number of both lungs?
2, 3.
Left 3, right 2.
Just the opposite. The opposite. Right is 3, left is 2 lobes. Just remember it like this. On the left side, there is heart as well. So there is not much space, okay? So because of that, on the left side, there is 2 lobes. On the right side, there is 3 lobes. Let's check it out. First, I saw the upper lobe on the right side. Then I see the middle lobe. And on the bottom, I saw the lower lobe. So middle, lower. The lower part has a superior segment as well. And the lower pole, the middle pole, and the upper pole here. On the left side, I'm seeing the upper pole, which is this one, and I'm seeing the lower pole here. So the upper pole has a lateral side and some branch which is going to the top as well. Okay, what else should we see? Let's check. Okay. Did this image have a contrast inside? Can you say anything about it? I'm seeing the chambers of the lung, chambers of the heart, filled with bright fluid, right? It's much brighter than normal soft tissue. Also, I'm seeing the vessels pretty bright than the rest of the soft tissue. So this patient has contrast media. This examination has contrast media, okay? We will check another without contrast, so you will see it better. Yeah, and this time, like this one, is without contrast. So let's see how it looks like. So when I check this patient, the chambers of the heart are not bright, right? I'm not seeing anything. It's completely gray. Also, the blood vessels have the same density with the other soft tissues. So there is no contrast media inside the blood vessels. And check out this one. It's much different, right? So you check the aorta, you check the blood vessels, and you can easily guess. Okay. We are seeing a 60-year-old male patient which is admitted to the hospital with shortness of breath and chest pain. The dude is saying that he has made a very long bus journey from Erzurum, the other side of the country, to Istanbul. And you ask this patient to your emergency specialist, abi or abla, and it orders D-dimer, which came as elevated, and also the patient has mildly elevated troponin levels as well. You look at the ECG, and there is nothing fancy inside it. What does anybody think of any typical disease for this patient?
Pulmonary embolism.
Pulmonary embolism, great. What else?
Artifact.
Artifact, like what?
Myocardial infarction, I mean.
Myocardial infection. We have to always exclude MI, right? Because MI is very common. Half of the class is going to die from cardiac disease. There's a 50% chance that we will get MI at some point in our lives and die. So MI is very important. Okay. Troponin.
But hocam,
Sorry.
hocam, the ECG is normal, so shouldn't it exclude MI?
ECG can a simple ECG exclude all of the MIs? Unfortunately not. Okay. For MI we have to look at many things. Like, I'm not the expert. You will learn about it in cardiology. But the ECG might be normal in MI cases. Okay. In big area MI, it's usually there is something abnormal, yeah, but not always. Okay, so does anybody want to have? Does anybody want to see this patient, please? I would very much be happy if we do this with somebody else. I'm sending this to chat window. We are not on an exam. Like, take it easy. Emre, can you volunteer?
Yes.
Okay, please share the screen.
Okay. Oturum sahibi katılımcının ekran paylaşımını engelledi diyor hocam.
Şimdi yapabilirsiniz. Tekrar deneyin.
Şimdi oldu sanırım.
Okay, Dr. Emre has opened the patient and he started looking at the. Are we looking at the lung window or the soft tissues now?
Şu an soft tissue ama
Soft
kontrast
tissues,
sanırım.
right? Yeah,
Evet.
this is with contrast through that. So we are seeing the contrast media inside the blood vessels. So or pre-diagnosis, one of the top pre-diagnosis was pulmonary embolism. Pulmonary embolism is embolic occlusion of the pulmonary arteries, right? So we are supposed to see something inside the pulmonary arteries. So can we go to the pulmonary arteries? When we check it from the lung window, we can only see the lung areas, right? So in order to see the blood vessels, we have to look at with the soft tissue window.
Soft tissue mu girmemiz gerekiyor aslında?
Yeah.
All right.
Okay.
Yes, this.
So Yunus Emre has detected some stuff, I guess, right?
Yes, in this area.
Yeah, there are some areas. Yeah, something not right. So there are some, but we have
embolism here.
Yeah, we have seen embolism, but we need to check if they actually connect to the pulmonary arteries, because there are pulmonary veins in a thorax CT scan as well, right? So you have to go to the top to see the main pulmonary arteries and follow it all the way down to the parenchyma.
Öyle yukarı çıkalım, en yukarıya.
En yukarıya niye çıktık?
Arterleri görelim diye.
Okay, that's the systemic arteries. The systemic arteries start with aorta, right? Now we need to find the pulmonary arteries.
I think these are pulmonary arteries.
Yeah, but the main pulmonary artery was somewhere else. Like, we need to look at the reverse Y big pulmonary vessels, Emre.
Bunlar olabilir mi? Are these?
They are pulmonary arteries, that's true. But we need to see the main trunk. The main trunk. I'm trying to draw, but I couldn't find it. Okay.
Bunlar mı acaba?
Ters Y işareti olacak bir yerde. Ters Y demiştim yani. Ters Y'nin olduğu yere gelelim. Ters Y'nin olduğu yer. Biraz daha yukarıya. Devam. Yeah, we are seeing that's the main right pulmonary artery, right? No, that's the smaller ones. We need to see the bigger ones. Okay, I was trying to draw, but yeah, like I guess my drawing is disabled for now.
Yeah, it doesn't seem.
Out of the reasons why I didn't understand. Okay, you can stop screen sharing. I can take the lead and maybe show. Okay, thank you. Thank you, doctor. So it's not this one, sorry. Okay, I need to find the big pulmonary artery and the right and left ones, right? As we have so the reverse Y or the X, right? That's what we need. So I'm starting with the main pulmonary trunks. When I start following them, The main trunk is empty, but after then, for starting from the right one, starting from here, like there were many things that you have also, like on the lower branches there were much more, but on the bigger scale, on the pulmonary left main pulmonary trunk, there's a very big thing which is not shining, right? Which is obviously not receiving any contrast, and here as well. So in order to see if it's a pulmonary vein or artery, we have to start from the center. All right. So if you look at this patient, thank you, doctor, for your good diagnosis. By the way, you have started from a very nice point. We are seeing a lot of thrombus on starting from the main arteries, and many of the lower arteries are also occluded by the thrombi. I got a question. We are seeing the thrombi, I understand, but when I look at this, it looks like like a line, right? Like a pen. It's straight. Can you sort of guess why it is straight? Not like a ball, for example. It is much smaller than the artery itself. It's like a very small, line.
I think that's the difference between thrombotic and embolic.
Thrombotic and embolic is usually the difference is on thrombus. Thrombus is located in the veins, and emboli are located in the arteries. That's the difference. So I'm actually trying to ask the shape, why it is straight.
Does it mean that blood isn't reaching that area? So that's why the...
Well, inside the blood vessel. This is inside, we are inside the blood vessel here. So all these shining areas are contrast media. Sorry?
Is it because it's blocked?
Yeah, it's obviously blocked. But why is something straight blocking up the arteries? Why they are not round? The reason is because they are coming from actually smaller veins, which are located in the legs, right? These are probably coming from the legs of the patient who has a very long bus ride, who was sitting for a very long time. So probably the patient has some thrombus in its leg veins, like femoral vein or the superior femoral, femoral vein or the main femoral vein. So when they mobilize, because these femoral veins are much, much smaller, so they come in the shape of the vessel they are coming from, right? So that's why they are in straight shape. Was it clear? No?
Yeah.
Okay,
Yes.
anyway. So we have field of first lecture. We will go on with the next one. We have less than a minute left. I will be sending the invitation right away, okay? Let's make a break afterwards. I can get the questions on the next one, all right? When everybody's gathering. See you around. Okay. So we have been covering up the case of a pulmonary emboli before, so I'm going on to the next one. We were talking about how the thrombi are taking the exact shape of the blood vessels they are coming from. So because these thrombus are probably coming from the femoral veins, they look like a venous structure, right? Basically. So pulmonary emboli is the embolic occlusion of the pulmonary arterial system. The majority of the cases are resulting from thrombus from other vessels, other veins of the body. So when these thrombi are mobilizing, they go all the way to the pulmonary arteries and occlude there, right? So the main, when you look at the physical examination, the patients are usually, the symptoms, the patients are usually have dyspnea. They can have some chest pain, which is mostly like pleuritic origin. If the reaction reaches the pleura, it can have some chest pain there as well. They can have cough and hemoptysis in moderate cases, and in very severe cases, because this turns out to be a circulatory problem in the end, the patient can have cyanosis, collapse, circulatory instability, and It is estimated that 15% of all sudden death are probably related to pulmonary emboli. So in diagnosis of pulmonary emboli, dimer count with ELISA. This is important because there are other ways to count the dimer as well. But most of the modern places now usually use ELISA for the test. Rules out pulmonary embolism. So we can use the dimer for ruling out embolism. But the dimer can increase in old patients, right? This is an acute phase reactant. So in case of arthritis, for example, the dimer also increase. So increased D-dimer doesn't mean emboli, but normal D-dimer means that there is no emboli. Okay. So, doctor, these can be all questions if you are curious about. So we can ask, because these are also very important steps in diagnosis. This was a question. This was a question for the previous groups, by the way. D-dimer, for example. For definitive pulmonary emboli diagnosis, CT pulmonary angiography is CT with contrast is mandatory. You can call it CT with contrast. You can call it CT pulmonary angiography. All of them counts. Sometimes, like ventilation perfusion scan is also like it's written on lecture notes, but almost these are never used. Like I've never seen a ventilation perfusion scan ordered to a pulmonary emboli patient. Also, catheter angiography these are found in lecture notes, but they never gets performed anyway. For patient who cannot order a CT scan out of this or that reason, maybe the contrast allergy or something, echocardiography can be helpful in differentiating the pulmonary hypertension, which can be caused by the emboli. Or in a pregnant patient, for example, what can we do? This is an important thing. For pregnant patients, how can we go for the diagnosis? Do you have an idea? We are seeing a pregnant patient, which is dyspneic, has high D-dimer, and the oxygen, saturation is also pretty much when you see them low. So the patient is in question of a severe pulmonary emboli. What can you do? Does anybody have an idea?
MRI. You order MRI.
MRI, pulmonary MRI angiography is very, very seldomly made. It's a very rare thing. Unfortunately, no. Other than that,
Ultrasound, does it help?
ultrasound to where? We cannot see the chest pulmonary arteries with the ultrasound, unfortunately, because it's covered by the lungs.
Doppler ultrasound
For pulmonary arteries?
For thrombosis.
For thrombosis. Very good idea.
Ventilation.
So, ventilation perfusion
perfusion
scan can be ordered also. I think Aman said something about detecting the thrombosis, right? It's a good tactic. So we can order a Doppler scan for the legs, right? Doppler scan for the leg veins. If we see deep venous thrombosis on the legs, and the patient has all the symptoms, so probably some of these thrombotic particles have also go up the way and made the pulmonary emboli. So we can try to diagnose going from the other way. Okay. Also, do you think that pulmonary angiography, like the radiation dose, can be a problem for pregnant patients? It is actually not. We know that even one abdominal CT scan have no teratogenic effect on a baby. We are sure of that. So making a CT angiography for a pregnant patient for thorax, because we are scanning thorax, right? Like we are not going for the abdomen. So it's actually safe. Also, contrast media usage, although in vitro it has teratogenic effects. This in animal studies, teratogenic effects of contrast media is never demonstrated. It can only have some thyroid disturbances on the baby. So on a pregnant patient, if we really need a diagnosis, CT angiography is also can be easily performed. Okay. We are seeing another patient with right lower quadrant pain. I'm checking at this one. The CRP is mildly elevated. We are seeing that, and the white blood count is pretty much on the limit, on the upper limit. The patient is obese. You ask the surgeon what to do. So because the patient is obese, the surgeon directly orders a CT scan. Okay. So I'm seeing an abdominal CT scan now. I started from the top part. I'm seeing the lower part of the heart. I'm seeing the liver. I'm seeing the spleen. I'm looking at the kidneys, right? So I'm seeing the small bowels on the middle. I'm seeing the large bowels on the periphery. So because the patient has the right lower quadrant pain, I wanted to see the appendix. For seeing the appendix, I try to find out the cecum first, because the appendix is gonna go up from there. So the start of the appendix is here, and it's a very small structure. Let me draw it. It's this one. So it has air inside, and when I follow it around, it goes like this. It goes lateral, it goes a little bit down, and it ends here. So when I measure it, it should be smaller than 6 millimeters. This is definitely smaller than 6 millimeters. So this is a normal appendix case. Also, I'm checking at the other organs. I'm seeing the bladder. I'm seeing no free fluid around the bladder. The aorta is fine. There is no free fluid inside the pleural cavities. So that's pretty much it. It's a normal CT scan with normal appendix. This was. So let's check an abdominal CT scan. I want to show you the brief gross anatomy of the abdomen in a CT scan. I will go with the axial view. Like this transverse view is always what we usually evaluate as a radiologist. So on the top, as I said, we start with the liver, and we can see the diaphragm borders here, which is bordering the thorax and abdomen. We are seeing the stomach, right? We are seeing the liver and the spleen and the blood vessels which are going to the liver. We see the portal veins. The pink ones are the portal system, and these ones, the blue ones, are the hepatic venous system. Also, the arteries are much smaller. The arteries are are marked in red. So the arteries is pretty much smaller. When you go at the portal triad, you are seeing the portal veins and the arteries, and the bile ducts, which I will not question this. Also the blood vessels, it's hard for you to grasp, I can understand. We can see the other solid organs like liver. I started seeing the small intestines, and I've started seeing the colon, right? The colon has haustra. The small bowels have I forgot. The small bowels have much more smaller tentacles. All right. I'm seeing the psoas muscle, which is lining right on the left side, on the right side of the vertebra. I'm following up the aorta. When I follow the aorta all the way down, it divides into two iliac vessels, right? The iliac vessels go down all the way to form the femoral veins. Also, they give a branch to supply the pelvic organs with the internal iliacs. On the lower part, I'm seeing the bladder. On a male patient, I'm seeing the prostate. On a female patient, I'm seeing the uterus and the ovaries. And from the cecum, I'm seeing the small appendix, which is actually a round structure, and diameter is limited to 6 millimeters. Please remember that one, which originates from the cecum and ends blindly. So it's not going to be connected to anywhere. Okay, this is a normal appendix. Okay. I think somebody has an open microphone. Abdullah, it's probably you. Okay, so we are seeing a 70-year-old male patient with abdominal pain, and the patient is obese at the same time. So surgeon examines the patient and orders a CT scan. Let me take care of this one as well. This is a CT scan with contrast, but it is on the venous side, so the blood vessels are not very shining so brightly. So I will show you the appendix. So you have to sight the cecum at first, and then from the cecum you have to see something originated, some round structure which is going to end in a blind manner, like not gonna connect anywhere. Because this is more like, if you measure this is probably close to a centimeter now, and we are seeing the small stone which is obstructing the appendix as well. So this patient has appendicitis. Some of the pathologies that I'm covering in radiology in these lectures are quite difficult, like appendicitis. So I'm not gonna ask you people, but for the major ones, I might be asking you, but I will go over them and tell you if I will ask them on oral exam, okay? Acute appendicitis is, this is not a hyper emergency actually, so the patient can stay until the morning in a case, but this is something that this is the most common thing that you're gonna see in a normal emergency, day, let's say. So I want to mention that acute appendicitis is acute inflammation of the appendix vermiformis. Okay, its age distribution is it has a two-peak age distribution. First of all, it's very common in children. Then after the mid ages, it usually goes down, and after the 6th decade, it usually gets the prevalence increases afterwards. So it's a very common condition in general radiology practice, and it's obviously the main reason for abdominal surgery in young patients, combined with gallbladder problems. CT is the most sensitive thing in diagnosis of appendix. I can ask that one, but usually for small children and for patients who are not obese, ultrasound is also highly sensitive. Like in case of an acute appendicitis, it's sensitive as much as 80%. Sometimes it's not detectable by ultrasound. So the golden standard is CT, but ultrasound is preferable in children. Okay, so when you are seeing patient with lower quadrant pain, it's something that you have to always keep in mind, appendicitis. But since you cannot order some imaging modality to every patient, what can you do in diagnosis of appendicitis? Like, how can you choose the patients that you are going to go for imaging? Have you got any idea for that?
The McBurney sign. There's some
McBurney
different
sign
signs.
is important. Yeah, there is that sign. McBurney point tenderness is also important. Also, white blood count is important, right? CRP, acute phase reactants are important. You check the CRP level, you check the fever, right? So there are many things that you have to consider. You can consider when you are making a diagnosis of appendicitis. But there is a scoring systems, people. So these like when you have many things to consider at hand, how can you make the final diagnosis? You should use the scoring systems. Alvarado and Append scores are clinically tested and validated scoring systems that you can easily use when on your emergency medicine practice. So when you evaluate the patient and score it using these scoring systems, they are highly accurate. And when you do this and decide to make the imaging according to these scoring systems, you are in the right side. Like, you can easily prove yourself in a case of malpractice, for example. So although I will not be asking you guys the radiological diagnosis of appendicitis, I can ask you about the imaging modalities and the scoring systems, okay? Not the names, but please remember that when you're suspicious about an appendicitis, you have to use scoring systems. So when you're working in pediatric radiology, for example, you always print out one of these scoring systems and put it on the wall somewhere close to you, okay? All right. So when we come to imaging, the imaging usually starts with the pathology starts with obstruction. So when the appendix gets obstructed, and because it has fecal material inside, it easily gets infected, and abscess forms inside it, and later then it ruptures. Okay. So fluid appendix is very important for us in radiology diagnosis. Also, some dilated appendix, which is bigger than 6 millimeters, is important. And because this reaction also spreads to the outer organs, like we are seeing some echogenicity increase in the periphery of the appendix in ultrasound, and the wall actually also gets thickened because of the inflammation, obviously. Appendicolite, these are very small stones. They are usually formed by the fecal remnants. It's thought to be like that. They are usually the ones which are obstructing the appendix. So when you're seeing a appendicolite in a patient, it's usually helping us in diagnosing. Okay. So when it gets inflamed, it swallows and it has fluid inside, and it gets obviously bigger than a centimeter. The ultrasound appearance is like this. The wall is thickened, it's much thicker than the rest, and it has fluid inside. Okay, so we are seeing a patient in emergency department, a 76 years old female, which is describing a sensory loss and dizziness on the left side. When you do the physical examination, you are seeing slight motor loss on the left side, and the physician on ward orders a CT scan. So I will check a normal CT scan of the patient. I've given you a clue, it's a normal scan, by the way. So when I'm looking at a normal CT scan, first of all, I start from the cerebral cortex. I look at the gray matter and the white matter. I check the ventricles of the brain. I'm checking the sulcus and the gyrus of the brain. If the gyrus are distinguishable between each other, and if I can see the sulcus, which is filled with cerebrospinal fluid. I check the lateral ventricles. I check if all of them are in place. I check if midline is staying the same in the midline, or bending towards left and right. So when I go down, I see the basal ganglia. The basal ganglia are usually looking up brighter. I see the third ventricle. When I go down, I see the fourth ventricle here. And behind the fourth ventricle, I see the cerebellum, right? The cerebellum. On the lower part of the cerebral cortex, I'm seeing the temporal lobes. On the front, we are seeing frontal, parietal, and the occipital lobes. And I'm seeing some areas which the cerebrospinal fluids are gathering up and making small cavities. These are called cerebral cisterns. They should be all looking in like normal cerebrospinal fluid, like low density. When I check the brain parenchyma, it's symmetrical. I can see the sulcus and gyrus everywhere, and there is no asymmetrical appearance. Okay. So when you're looking at a normal CT scan, you have to check the gray and white matter you have to check the sulcus, you have to check the subarachnoid space if it is dark in nature. You have to check the ventricular system. There is the lateral ventricles, the third one, and the fourth one, which is in front of the cerebellum. You have to check the basal ganglia, which is brighter, which is closer to the front, the cerebral cortex, and the midbrain and the hindbrain, which is pons and medulla oblongata. Okay. So we are seeing a patient on emergency again with sudden deterioration in Glasgow coma scale, losing consciousness, and which is brought to you to emergency by relatives. The patient is told to have received warfarin for a metal heart valve. So the physician on board orders a CT scan immediately. Okay. Should I check this one, or does anybody volunteer? Let me check this one by myself. Okay. So when I look at this patient, when I start from this patient, first of all, I don't see the sulcus, right? So the gyruses are here, like the cerebral parenchyma is here, but the sulcus are not present, as you see. And when I start go down, I'm seeing that the lateral ventricles are pretty much looking asymmetrical, right? So the midline is shifting towards the left side, and I'm seeing something pretty bright on the right occipital and parietal lobes here, which has got also a hazy appearance, and looking at the brightness level, it is pretty bright. Can anybody think of any pathology which is causing this?
Hematoma.
Hematoma, great. What else? Mass, why not? Right? Maybe a big mass. Hematoma and mass and many others like abscess, this, that, it can be caused by that. But this is pretty much bright, actually very bright. Hematomas in CT scans are usually brighter than the normal tissues because they have a lot of hemoglobin inside, they have a lot of thrombocytes inside, and also a lot of fibrin. Like those proteins, the thrombocytes and the erythrocytes are making up a very dense mass, which is high on protein. So though it is usually bright. Also, when I look at the lateral ventricles, I have recognized something else. Like this is the lateral ventricle, right? So on the top of the lateral ventricle, it is normal cerebrospinal fluid, which is dark, right? But on the bottom, this is much brighter. So obviously the bleeding has also opened to the ventricular system, and it has started leveling down inside the ventricles. All right, this was a typical case for intracerebral hemorrhage. So I wanted to show you. Okay, let's move on. We are seeing another patient which is 35 years old with sudden loss of consciousness. Okay. I'm looking at the typical axial CT scan now. I'm checking up the brain parenchyma, the ventricles, the cerebrospinal fluid and everything. Does anybody recognize something?
Leading present.
Where? I'm seeing something, right?
Everywhere.
Everywhere? No, not everywhere. Not everywhere. The subarachnoid spaces are quite nice, right? Everything is normal. So
it's in the pontine region.
It's in the pontine region, right? Through that, it's in the pontine region. So when I look at the brain parenchyma, it's normal. The gyrus are here, the sulcus are pretty much in place. Like midline is on the midline. The midline is also, you check the midline from here. So there is no bending or anything. So there is nothing which is causing the asymmetry. And but when on the basal ganglia, it's all clear also. But on the pons, on the pontine region, we are obviously seeing something, some hematoma here, right? Which is quite bright. So the bleeding, because the bleeding is on pontine region, the patient has experienced a sudden onset of reduction in Glasgow Coma scale. It's also a very common emergency which can happen in any age. These because these are usually related to hypertensive episodes or some vascular malformations also. It can happen at any age. So when you are working in emergency department in a Turkish hospital in Zorunlu Hizmet, many of these CT scans are going to come to you as a normal scan. So you have to look at your CT scans by yourself all the time, even if you know how to evaluate or not. So it's very important for you to actually know the imaging behind all these pathologies. Okay. We are seeing another patient with right, the CT scan actually disappeared. Okay, we didn't include the CT scan here. Can you see the pathology? I think you can see the pathology, right? It's on the basal ganglia here. Here on the frontal lobe. We are seeing another patient which acute onset of weakness and altered consciousness. So does anybody want to volunteer? Yara Kasim, can you share your screen? We can look at together.
Yes, of course.
All right. Great.
I just want the link.
Sure. Here you go. Please don't forget to share the screen so that we can see it together as well.
Am I sharing it? No.
Maybe you're not allowed. Okay, now you're allowed. Now you're allowed. Sorry.
Yes. Yeah, here.
Okay.
So the patient who had I actually forgot. I think
Yeah, I think we are having trouble with your internet connection. Your video is looking.
No.
Yeah, I think. Yeah, unfortunately, you are having trouble with the bandwidth, I think. Okay, let me show it myself then. Thank you for the attempt, at least. Thank you for the attempt. If you can stop the screen share, I can move on. Okay, thank you. But I think you have also recognized the case, which was right. It was in Pontine region, right? Again. It's actually on only the left side of the pons. So the patient is experiencing right-sided weakness. And on the upper brain, I'm not seeing anything. So there is a marked bleeding on the pons. Okay. Let's move on to the next patient. So this patient has malaria and in an episode of complicated disseminated intravascular coagulation. The patient starts to experience a sudden onset of headache and altered consciousness. So when I will take the I will open the patient now. So when we are looking at the patient now, we are seeing something, some different state, I guess, right? So does anybody notice anything? I'm open to suggestions.
I think it's here.
This time I'm seeing it on the upper brain, right? But it is pretty much disseminated. Like it's here, here, here. These are all bleeding areas. Also, when I look at the lower parts, I'm seeing some stuff on the deeper brain, some stuff closing to the corticomedullary junction. White, I'm sorry, like subcortical areas.
So, doctor, how do you know if it is bleeding or infarctions?
We will come to that because I'm knowing these are bleeding because first of all they are bright, so they are more dense than the brain parenchyma. But if is this a infarction case which has bleeding inside, like we will come to that. Maybe they can be the case as well. But in this case, these are obviously bleeding cases because bleedings are denser than the normal brain parenchyma, and we know the background of this patient as well. The patient has disseminated intravascular coagulation, which means the thrombocyte levels is close to around like 10-20,000 in this patient. So spontaneous bleedings are they happen quite a lot in these patients. So this patient is experiencing episodes of intracranial bleeding, spontaneous intracranial bleedings. So intracerebral hemorrhages can happen from many obvious reasons. The primary hemorrhages usually happen because of the lobar hemorrhages in older age individuals, according to resulting from angiopathies, and most of the cases result from hypertensive episodes or vascular malformations sometimes. The secondary hemorrhages can happen from causes which have other underlying, like when there's something you can identify, it's secondary hemorrhages, like malformations or thrombosis or tumors or trauma, for example. So when you are seeing a patient with an intracerebral hemorrhage, there are things that you should consider in terms of radiology. Like you have to always pay attention to the location of the patient when you are referring to a patient over the cell. Okay. So we were left in a case of intracerebral bleeding case in a patient which was receiving warfarin because of a heart valve, and we went through a case of intracerebral hemorrhage because of low troponin levels in a case of disseminated intravascular coagulation. The causes of intracerebral hemorrhages the etiologies are very diverse, so it's not going to come to you as a question. But what is the important points when you encounter a case of intracerebral hemorrhage is pretty important, because the location is the location and the size of the volume, of the hemorrhage directly is related to the clinical course of the patient. If this hemorrhage is causing a shift in the intracranial distribution, then it can cause herniations, and herniations are most of them, like especially the ones which are related to the lower parts, are very fatal. Presence of hydrocephalus, the enlargement of the ventricles, are also important. If the whether the hemorrhage has opened into the intraventricular space or not is also very important. Active bleeding is very important, but you cannot differentiate it very easily using non-contrasted methods. So we have come through this patient, and we'll be coming up with another case. This time it's a 50-year-old woman who was brought to emergency department with altered consciousness and confusion, and after taking a laxative in preparation for the colonoscopy. So the patient is receiving laxatives before as a colonoscopy preparation, and she doesn't have any remarkable history or anything, and at the ER she went to stuporous, and the Glasgow coma scale is dropping down. When you take the blood work, can you see anything in the blood work, by the way? Anything which is catching your attention?
Acidosis, she has.
Acidosis, true that. What else?
Low bicarbonate and low sodium.
Sodium is 111, right? This is very low. This is very low sodium. Also, acidosis is the patient is very acidotic, by the way. So let's, because she has cognitive symptoms, they make an imaging for the brain. I opened the CT scan. Does anybody notice any abnormality in this scan? I'm open to suggestions.
Okay. No.
Actually, there is diffuse swelling in the brain.
Diffuse swelling, right? Diffuse swelling. Where is the subarachnoid space? The subarachnoid space is completely obliterated in this patient.
Cannot be seen in
We
this
are not
patient.
seeing any sulcus, right? Where is the sulcus? The sulcus are not present. The gyrus have stick to each other, right? And I'm checking at the ventricles. Look at the ventricles. The ventricles are pretty much also collapsed, right? Like I'm seeing hardly the lateral ventricles, and where is the third ventricle on the midline? The third ventricle is gone. The fourth ventricle is here, is a very small dot here, looking like a very small dot. Also, the cisterns, you know, the subarachnoid, cerebral spinal fluid collections. Let's see, around the pineal gland, for example, on the top part. It's like everywhere in the brain. So there's complete swelling on the cerebral parenchyma. It was a very quick diagnosis. Thank you, doctor, for your quick diagnosis. This patient has cerebral edema due to severe hyponatremia. So as we are going further, I recognize that you have started seeing. You know what a normal cerebral parenchyma should look like and what it shouldn't look like, which is a good thing. All right, this was a good demonstrative case. I really like this. Let's move on to the next patient. We will do a little more. So can you see the abnormality here? I think you can see the abnormality, right? The patient has received, well, there's a lot of abnormalities. There are multiple abnormalities, to be honest. I think this is the entry wound, and this is the exit wound of the bullet. So there are multiple areas of hemorrhage inside the brain, which are looking brighter than the cerebral parenchyma. And also there is blood in the ventricular space, right? These are the lower parts of the ventricles. I'm seeing bleeding areas there as well. Also on the top part of the lateral ventricles. One other thing that we can mention is when you look at the parenchyma here, right? There is no trauma here. So we are on the above level of the trauma, superior level. We are seeing the same thing, right? We are seeing the same thing. The brain is swollen and it's obliterated all the cerebral spinal space. The subarachnoid space is totally obliterated. We are seeing small areas of bleeding, which is covering up the walls of the subarachnoid space and the falx cerebri here. So yeah, this was quite obvious, but I wanted to put this patient because of this is an example for cerebral edema. Okay, I'm seeing stuff at chat window again. Okay. Okay, people, I'm really having hard time seeing the chat window, so please open the microphone, okay? So we are seeing another patient with tonic chronic seizures and which has fall down, hit the head, and which is breathing from the right ear. Okay. All right. So I'm starting to move the slides, and I'm open to your pre-diagnosis, all of your pre-diagnosis. Please contribute. I'm seeing hemorrhage areas, right, inside the parenchyma. These are all hemorrhage areas, a lot of them. I'm also seeing some type of hemorrhage which is not inside the brain actually, but covering up the outer wall of the brain, right?
Hocam, the ventricles are symmetrical.
Ventricles are, okay, let me draw the midline. Ventricles
Yeah.
are not symmetrical, right? Not symmetrical. There's a little bit of a shift as well, right? On this side.
Yeah.
Good catch, especially here, right? What's the reason? The reason is because of this one, I think.
Yeah.
It has started to push the brain here, so there is a little bit of shift here, a very small, some millimetric shift. Okay, I'm seeing some other areas of hemorrhage as well. So this time the hemorrhage here is within the brain, right? This is within the brain, I can see that. But this is not within the brain. This is covering up the space which is outside the brain area.
Is this subdural hematoma?
What can you call this? Subdural is a guess. It's a good guess. What else can it be other than subdural?
Epidural.
Let me show you something subdural, doctor. The subdural is something which should be under dura, right? Subdural, as the words say. It should be under the dura, and it should be above the arachnoid space. So it should be lifting the arachnoid space a little bit, and because it is subdural, it should be pretty much like look pretty much flat. This is a subdural collection, for example. The patient is having subdural collection, which is actually not bright. It's pretty much like a little bit higher than the density of this cerebral spinal fluid. So I can exclude the bleeding here. It's not bleeding, but the patient probably has chronic subdural collection here. I can see that. What are the things that I'm seeing here is, I think, below the dura, and dura is on the very periphery, below the dura, but also below the arachnoid space as well. So it is actually within the cerebral spinal fluid. So what do we call the hemorrhage areas which are under the arachnoid space?
Subarachnoid.
Subarachnoid.
Subarachnoid, right? So the patient, we are seeing subarachnoid hemorrhage areas here. The subarachnoid hemorrhages, people, because they are in the subarachnoid space, they are basically where the cerebrospinal fluid is. So they paint the areas, they cover the areas which are where there is where there is cerebrospinal fluid. So if you look at this, there's a very small area of bleeding which is going right perpendicular to the bones. Can you see it? This is a typical case of subarachnoid hemorrhage, like these areas, these small lines. So these are typical cases of subarachnoid hemorrhage, and these are a little bit untypical cases of subarachnoid hemorrhage. There is also parenchymal hemorrhage here as well. Right? The parenchyma is bleeding to the subarachnoid space, so it's all mixed. It's all mixed actually. Okay.
Peki Beyaz parlak yerin dışındaki yerlerde mi kanama
Like
onlar?
this
Ne tam
one.
olarak?
This one is intraparenchymal hemorrhage. Gördüğünüz bir şey var mı? Yani nerede görüyorsunuz onu? Beyaz kanama alanlarının dışında bir şey.
İskeletin dışında böyle deri mi onlar acaba? Kafatasının dışında.
Kafatasının dışında. Bunlar yumuşak dokular. Yani kafatasının üzerinde bir yumuşak doku olması lazım. Yani bunlar kas mesela. These are temporalis muscles. Temporalis muscles, symmetrical. Okay. Bu muydu sorunuz?
Aynen. Tamam hocam, sağ olun.
Okay. There is some small area of bleeding here as well that I'm detecting, which is this one here. So this is also another area of subdural bleeding because it's very thin. It is very thin. It doesn't have convex angles. It doesn't make any convex angles with dura, and it's due to the trauma as well. Another area of subarachnoid hemorrhage. Okay, this is pretty much it for this case. Also, so we should look at the other windows. The patient has other windows as well. So let's check here what we can see. If we can see anything. Everything was pretty symmetrical in my case. I'm seeing the sulcus, which are symmetrical, right? Did anybody notice anything? We are seeing an intracranial fracture here, starting from the temporal space, and it goes up from here. All the way to, it goes, I think somewhere, it stops here, somewhere around in the parietal bone. So we are seeing also a cranial fracture because the patient has fallen down. It goes all the way to temporal bone, and that's the reason why the patient has bleeding from the ear. Okay. Was it clear? This CT scan is not a very high quality one. Probably the ones that you are going to be working with in small hospitals are going to be like this as well. So, can you see the cranial fracture? This? Is there anybody that didn't see it? Okay. Okay. So, traumatic brain injuries are usually more common in young patients, especially in men. So most of them are due to motor vehicle accidents, assault, and in Turkey, usually most of them occur from falling from constructions, usually. So the severity of the injury can be classified with Glasgow Coma Scale, and of course with your findings on CT scan. Okay. Let's see another trauma case. The patient is hit on the head with a heavy falling object. Okay. So what are we seeing here? Can anybody explain?
Epidural hematoma.
We are seeing a epidural hematoma, right? We are seeing
Also,
some hepodama which is not inside the parenchyma, right? Which is somewhere
there
else.
the skull and the skin outside.
It also looks asymmetrical, right? There is some bleeding in the outer part as well through that. Okay. What else? There's some asymmetrical appearance on the parenchyma as well, right? Because when you're referring the patient to some other doctors, you should always mention these properties as well. So we are seeing some shift here, also because of the bleeding. The bleeding is probably pushing it to the other side. All right. So This is epidural. That's true. That doctor, why did you call this epidural but not subdural?
I think football-shaped collection of blood.
It's got reverse angulation, right? Like if it was a subdural, it would be pretty much looking like this. It would be more flat, because in epidural, because this is bleeding from the upper part of the dura, it is pushing dura, which is sticking up to the bone very firmly, actually, and it is trouble passing to the other side, to the frontal lobe, to the frontal bone, right? Because this is the parietal bone, this is the frontal bone, okay? So it cannot cross the sutures, which is very important. But subdural is not like that. Subdural hematoma is under the dura, so it is actually lifting up the arachnoid space, and arachnoid space is like everywhere, like this subarachnoid. If there was a subarachnoid space here, bleeding here, the bleeding can even go down from foramen magnum, so it can go anywhere. But in case of an epidural, it's not like that. The angulation is pretty perpendicular, not flat like this. So it's a typical case of epidural hematoma. That's true. Thank you for your diagnosis. It was a very good one. We can check the bone window here and see the fracture here, obviously. Okay. This is usually the case with middle meningeal artery, right? The middle meningeal artery can easily bleed after temporal and parietal fractures, and very commonly cause epidural hematoma. Thank you. Okay. We are seeing another patient with motor vehicle accident. I will be checking up this one as well. What type of hematoma we are seeing, people?
Epidural.
Is it epidural
again.
also?
Epidural again, right? Epidural, through that. Okay. This one in parietal bone as well, parietal bone, but it has spread to the frontal side as well a little bit. So there is some subdural content as well. This area like this is subdural, but this is epidural. Okay. Good one. We are seeing some shift, right? So this patient is getting into danger. So it's probably a candidate for surgery. And what else? Can we see anything else in the brain? Let's look at it. There's a very small amount of intraparenchymal hemorrhage after traumatic brain injury.
Hocam, can you show me the subdural again? The subdural part.
The subdural component is not, it's not very obvious here. So yeah, it's here, like this one. This one is subdural. Because epidural is usually pretty much like it has an acute angulation with the bone. But when it is going like this, it is the subdural component. Also, I guessed it because of this. Like it after, like on the inferior parts, it's usually having this very small subdural components. Like I saw this one, and because I know this is subdural, I started looking for other subdural components. Also, the brain is a little bit. The brain has a little bit edema, right? Can you see, like on this side? It's hard to detect the. It can be also because the brain is being pushed here through that, but the density of the brain is a little bit also decreased, in my opinion, generally. Okay, let's check let's open the bone window and check the fracture of the patient. You can see the fracture easily. That's a very obvious one. Okay, another trauma patient we can do. Whoa. Okay, so in our emergency document, there was a case there was the case of this small kid who has fallen down, a two-month-old kid, CT scan. I will quickly go over it. So I'm checking the brain parenchyma. It's all symmetrical. There is no subdural bleeding. There is no intracranial bleeding. There is no epidural bleeding. This is also symmetrical, right? It's a part of frontoparietal suture, so the dura is a little bit thicker than usual here. I don't call this I don't call that a collection. So I will check the bone window from here. So looking at the bone window, I'm seeing a lot of irregularities in this brain, right? A lot of irregularities are present. So am I going to call them fractures? Is this a fracture, for example? Yes?
No, because he's a baby. I think
It's a baby, right? These are sutures, right? Okay. And these are fontanelles, right? Anterior fontanelle is here. It's pretty open, actually. You can touch the brain from here in small babies. So how can I differentiate the sutures from fractures then? That's so, because sometimes small babies can have fractures as well, right? So how I'm going to differentiate the fractures in small babies? What is the differentiating factor between fractures and sutures? First of all, sutures are in midline, right? They're pretty much in the midline and they don't diverge, unless in the case of occipital lobe. And even if that's the case, they usually diverge in the symmetrical manner. Like frontoparietal lobe sutures are usually pretty much symmetrical, right? So these are the two things I can differentiate a fracture from a suture. That it should be on the midline first, and it should be symmetrical. If it is symmetrical, then it's probably a suture. What else? Can you think of anything else? The sutures.
I think
Yes.
if there was a fracture, there will be hematoma.
Yes, very good, very good. Yeah, accompanying soft tissue component, right? Like if the soft tissue is swelled there or there's some hematoma there, it's probably a fracture. Good one, doctor. That's a good one. There's one other thing, one other small thing. The sutures are basically. Can you see my hands? The sutures are actually bones which are sticking right next to each other, right? So they usually have some this sort of an appearance, like zigzag appearance towards each other. But fractures are not like that. Fractures are usually straight lines, like resulting from trauma. Like in this case, for example, this is a fracture, right? And the fracture here moves on with the diastasis in a suture, right? So it actually, in this case, it separated the suture together. So that can also happen. We can see that. In one or two slides, it went on from the suture side and it went on to temporal bone afterwards, after this. So when I see a fracture, it's usually pretty much straight. Suture is usually have zigzags, a lot of zigzags on the way. And the symmetry issue and the accompanying soft tissue or hematoma component can easily help us in differentiating this. Okay, thank you a lot. Thank you very much. Okay. So in this case, for example, we are seeing a fracture which has swelling component and which is definitely not symmetrical, right? Suture, suture. This is suture, but this is fracture. Because sutures are symmetrical and they have zigzag appearance. So this is a case of frontal sinus fracture. It's a case of high energy trauma, probably fell down from more than its height or some motorcycle accident, something. So we are seeing a fracture here, which is actually, it includes the both sides of the frontal sinus, and it includes also ethmoid bone as well, because I'm seeing a lot of fluid inside the ethmoid bone as well, ethmoid cells. On the top, it goes on like this with the frontal fracture. So this patient is quite in a quite a risky situation now. Can you know the reason why? What is the risk in this patient?
Bleeding?
The risk is infection, because there is a fracture which is going on through the sinus, right? And the sinus is opening into the intracranial area. So this patient definitely needs to receive antibiotics. Also, one other thing is that from these kind of fractures also CSF leakage can occur. Cerebrospinal fluid can leak through these areas and leak through the bone. Okay. So in terms of trauma patients, always look for the site of injury. You will be having the patient in front of you. You have an advantage for that. Many of the things can be misdiagnosed. Like a lot of traumas are misinterpreted by tired radiologists or bored radiologists. So radiologists also make a lot of mistakes. Always interpret your own patients. So when you look at the intracranial bleeding parts, we have been talking about these intracranial bleedings. It can be above the dura, it can be below the dura, it can be below the arachnoid space, which means the cerebrospinal fluid, and it can be intraparenchymal, right? So we have seen some patients before. I will quickly go over them again as well. These are epidural hematomas. This is an epidural collection. Like when we are seeing a very bright collection, we are always suspecting it's a hematoma. When we are seeing a low density collection, we are more of thinking like thinking of chronic processes, like a chronic epidural hematoma, which is rarely happens actually. When it is below the dura, it doesn't have an acute angulation with the bone. It can go through the sutures, so it can start from the parietal bone, it can go to the frontal bone and to the occipital bone, which rarely happens in epidural hematomas. Okay, so if it is usually very flat and going all the way to the other bones, we can call it subdural. When there is hemorrhagic component, it looks bright. When there is no hemorrhagic component, it just looks like cerebrospinal fluid. So it is low density. Like if you pierce through this, and if you can go there with an injector and just aspirate this, some yellow thing will probably come out of this collection. When it comes to below the arachnoid space, it actually bleeds into the where the cerebrospinal fluid is. So it's going to cover all the places where cerebrospinal fluid is usually. I got a question. When you see something like the patient on the right here, what is the let's speak about why is this patient is under very big risk, and what is your pre-diagnosis? Can you think of something in a case of extensive subarachnoid hemorrhage? You should always think of aneurysmal bleedings in case of an extensive subarachnoid hemorrhage like this, because the middle cerebellar arteries, anterior cerebellar arteries, the main trunks of these arteries are usually going through the cerebrospinal place, so cerebrospinal fluid place. So in subarachnoid place, when there is extensive bleeding, always think of aneurysmal bleeding, and always you have to make another imaging which contains the like angiography, like MRI angiography, catheter angiography or something. Okay. So this was a question in your document, sorry. I always call it documentary. There was this small baby which fell from its father's lap, which fell from basically like 1 meter. It cried, it didn't vomit at all. The patient is alert, the baby is alert, there's no problem eating anything. And you observe the patient for a few hours, it's normal. But the patient's relatives are always asking you for a CT scan. What is the course of action? What should you do?
You
How
should
can
do the
you-
CT scan.
Why?
Because vomiting, I think.
No vomiting.
Oh, no vomiting.
Then
Yeah.
no, you should. I think so.
Or vomit once, but not twice. Or are you going to change your attitude if the patient is asking for a CT scan, which usually happens in Turkey, by the way. So there are many things that we should consider when we are looking at a trauma patient, just like the appendix case, okay? So there are many things to consider. You can be experienced or inexperienced. You can be tired, or you can be simply very exhausted, or you can be sleepy. So it is not very easy to evaluate in this case or make a decision by yourself. So there are the people have talked about this problem for a long time, and just like the appendix case, and just like the many things in medicine, there is always some people in many places, not everywhere, but in many places there are people who have thought about the problem and make the scientific approach to choose the right imaging or treatment method for the right pathology. So you have to find the guideline for your specific problem and look at it. Okay, always remember this, because you cannot remember the I'm never gonna ask you these specific indications, because they might change in the future. Like you have to, like after 2 years when you go into service, maybe you're going to be looking at a different algorithm, but the existence of algorithms will be there. So you should always try to look for some guideline, some algorithm which is proved and which is widely used, and make your decisions according to that, okay? Especially in trauma patients. All right. We got 5 minutes. We got another patient. Let's do this one. We got 20 more going on. There's a 50-year-old, 55-year-old male which came with right side hemiparesis. The right side of the patient is not working, so you give the patient cold stroke, and the emerging physicians on ward performs a CT scan and an MRI scan. Acute left-sided hemiplegia. Good one. Acute. All right. That's not right, by the way. Anyway, the patient has hemiplegia. So I'm looking at the CT scan. Looking for bleeding. That can happen with bleeding as well. Can you see any area with bleeding? I can't. It's pretty much symmetrical everywhere. There is nothing dense. So, does anybody recognize some asymmetrical appearance in anywhere? Let me stop here. So, when I'm looking at the sulcus on both sides, I can see the sulcus and the white and gray matter on this CT scan pretty nicely, but on the right side, but not on the left side, right? Where is this sulcus on the left side? So there is some area of swelling in the brain, but this time not global. There is some local asymmetrical appearance. So the area on this side is probably obviously have edema, and this area actually corresponds to some arterial territory, like middle cerebral artery territory. When the patient also has ordered some MRI scan, I'm looking at the diffusion MRI, axial DWI scans. When I look at the diffusion MRI scans, it is definitely more obvious that the patient is having a period of stroke, which is related to middle cerebral artery. So the patient is probably having an ischemic stroke, which is related to middle cerebral artery. Because I see the stroke in a territorial region, I can easily guess that. Okay. So we got like 2 minutes in this presentation, nothing much left. Let's move on to the other one. Does anybody has got questions? We will go over this with details in the next lecture. Okay. I will be sending the link. See you. finished the lecture beforehand. Let me share my screen, guys. Okay, people. All that we have. Last we have seen a case of ischemic stroke. I knew it was ischemic stroke because it belonged to a territory, right? Like also, if it didn't belong to a territory, it would also be maybe hemorrhagic stroke or ischemic stroke. Because there is no hemorrhagic stroke and there was ischemic areas, it was ischemic stroke. And now, because it belonged to a territory, I knew that it was coming from the left middle cerebral artery. I'm not going to ask you the territorial facts. It will be a little bit too much for you at this stage, I think. So I will go over I will look at another patient with another ischemic infarct. It will be a little explanatory for you. That's the reason why. So another patient with left side hemiparesis, then we are giving a cold stroke, and the hospital obviously have a CT scanner at hand, and they perform the CT scan. So I'm looking at the CT now. Everything is in place. The sulcus are okay. The ventriculars are okay, symmetrical. There's no shift. I didn't see any area of bleeding, so it's definitely not hemorrhagic stroke. Sort of. Can anybody see some small asymmetrical appearance in anywhere? I'm seeing small darker areas, like very faint here on the right side of the patient. Because it also corresponds to the patient's complaints on the left side, which is on the opposite side. It can be something like that. The patient has some CT perfusion scans here, which is a little bit too much for you, so we can just skip these ones. This patient had mechanical thrombectomy. So they go with a catheter here to try to take out this thrombosis, which is causing this problem. So later on the same day, the patient has another CT scan. Let's check it together. It's pretty much everything is in place still. I started seeing some small areas of bleeding in a few areas. Okay. And also I will show to you this also later as well. It doesn't appear here, but I'm looking at the CT scan which is taken later on that day again. We will go with other examples. It's not easy to see. On subarachnoid space, as we have talked, the blood vessels are running through that. Because when I see a thrombus, like with cellular components and everything, when I see an hematoma, it looks bright on CT scan, right? As in the case of an intra-arterial emboli, it also looks brighter, as in this case. And the patient's right artery is obviously brighter here. But it's a very difficult diagnosis anyway. It's not our point. Let's come to this one. The CT scan which is taken one day after. And look at that. Now I can see it, right? Now I can see something. So until one day, the cerebral parenchyma was looking obviously like almost completely normal. Now I'm seeing some edema here. The sulcus are indistinguishable. The gyrus are indistinguishable from one another. It looks when there is edema, the density is getting lower because the water inside this tissue is increasing, right? If the water is increasing, it should look more like cerebrospinal fluid, so it is getting darker. Also, I started seeing small amount of shift to the left side because there is swelling here, and the day after, the shift is getting increased, unfortunately. The area is, the borders of the area is much more distinguishable from one another now. And the day after, we are seeing that the neurosurgeons actually operated the decompression surgery for this patient because it started pushing up the brain parenchyma to the other side, unfortunately. Okay, so this was a course of a patient with ischemic stroke. I wanted to show you this just for you to see the performance of the brain CT on image on ischemic stroke. So let's go to our lecture slides, and look at it at a theoretical level. Starting from the beginning, ischemic stroke is the episode of neurological dysfunction due to focal infarction in the central nervous system. It can be thrombotic, emboli, or critical hypoperfusion. So in case of emboli, like we have seen, when there is thrombus inside the artery, we can see territorial infarcts. So when it happens in thrombosis, like when it happens in the venous system of the brain, can it cause ischemic stroke? It can cause ischemic stroke as well because of venous ischemia. Okay. Also, some cases of critical perfusion, like one patient, imagine a patient with carotid stenosis, for example, and the patient goes into a myocardial infarction. So the arterial tension decreases to 70, 80 something. And because of the stenosis, it can cause hypoperfusion inside the brain, which can cause ischemic stroke without any thrombosis or emboli. It's the second most common cause of morbidity worldwide. So the clinical of the patient really vastly differs according to the region which is affected, right? You can see if the patient is, for example, having a thalamus infarct, which is a basal ganglia infarct, some patients usually feel some episode of numbness, and that's all, nothing else. If the area is affected is middle cerebral artery, then usually they go into they lose consciousness, and you can see unilateral hemiparesis, for example. So in terms of the diagnosis, diffusion MRI is the golden standard in ischemic stroke. And we have seen the performance of CT, so I'm not going to go into detail in here. So diffusion MRI, you can start seeing the affected area minutes after minutes after the incident. According to the region, of course, when there is not very critical hypoperfusion, like there was a small thrombus which is not affecting the circulation, sometimes it's very faint and you cannot see it in 1 or 2 days. But usually in a typical case, minutes after the incident, you can see it inside the MRI. But in the CT, unfortunately, look at the fifth number here. The middle cerebral artery territory infarcts is visible only 60% to 70% in the first 6 hours. So if you have a normal CT scan with a stroke patient, it doesn't imply that the patient is not in stroke. Okay, please remember this one. And what are the things that we should look for in a CT scan? Loss of gray and white matter differentiation. When there is edema, the gray and white matter, it will be looking all dark. Okay. The cortical hypodensity, the dense middle cerebral artery sign is, I'm going to show you some examples of this, and that's basically it. So dense MCA sign is maybe one of the first things you can see in a CT scan, unfortunately, which is not always obvious because not all the strokes are middle cerebral artery stroke. Anyway, so these are typical cases of middle dense MCI sign. So because there is like hematoma inside the artery now, so the hematoma is bright, just like intracranial bleeding. Okay, you can think of it like that. So there was this woman that I have showed you when we are looking at a normal CT scan, this old woman with sensory loss and dizziness on the left side. As we have checked it before, the CT was completely normal. I showed you her CT as a normal CT scan example. So what happened is that the patient goes to University Hospital the next day, and when they do a diffusion scan, they find a very small area of diffusion in his basal ganglia. So basal ganglia infarcts are sometimes coming up with very mild neurological examination symptoms, okay? It can happen. When we are coming up to this patient was in your document, if you remember. And there was this old patient with lower quadrant pain. She was vomiting, and she had atrial fibrillation, and she has diabetes mellitus. So, what was our pre-diagnosis in this patient?
Maybe because of atrial fibrillation, there is a thrombus.
Where?
I don't know.
Yes, here. It's written actually here. Let's check this patient. So this is a woman with acute pain when vomiting for 1 day. Okay, she has atrial fibrillation and hypertension and diabetes mellitus. So when I check the X-ray, it was completely normal. But when I check the CT scan, you're not responsible for this, so it's very hard to see. As a case of pulmonary emboli, as you remember, like there was some thrombus inside the artery. This is the superior mesenteric artery of the patient, and after some time, the brightness suddenly disappears, like there is some thrombus inside the superior mesenteric artery, obviously. Like afterwards, it gets filled up with contrast again, but this is slowing down the circulation enough so that the bowel walls here are usually quite thick than normally it is. So this patient is taken to a surgery the same day, and it was the all ischemic areas have been resected. Okay, so in case of patients, especially old ones, and thank you, doctor, for making the connection on some. If the patient has some underlying factor like atrial fibrillation, for example, or coagulation problems, it can be that as well. Refractory pain, which you cannot alleviate with painkillers, and like bad clinical examination, which the patient is having severe pain that you cannot reevaluate, and you're basically not seeing anything, you should always think about mesenteric ischemia. This is a very hyper emergency as well. It has a tremendously high mortality, like 90%. So the clinical is variable with the underlying cause. Sometimes this happens in patients with MI, for example. The MI causes hypotension, and after hypotension for a very long time, they go into mesenteric ischemia. But the typical is thrombotic occlusions, embolic occlusions. Severe abdominal pain that is disproportionate to examination findings that respond poorly to analgesia is a classic type, okay? The bad thing about this is that there is no specific laboratory test to exclude the diagnosis of mesenteric ischemia, unlike pulmonary embolism, for example. Acidosis happens because it's some ischemic tissue, right? And lactate levels get elevated, but it gets elevated at a later period, unfortunately. When there is necrosis, it increases lactate, but it's usually too late, okay? So can you use the dimer for exclusion? If you have a negative D-dimer with ELISA, it's usually mostly exclude with a relatively high sensitivity. But unfortunately, the thing is in older patients, there are a lot of patients. D-dimer is usually high in all patients. That's a big disadvantage. So that was it. The X-ray was normal in that patient, but in a typical case, because the bowels get dilated, because the peristaltism just disappears because the tissue has necrosis, and gas is produced. So this gas gets the small bowels dilated, and you see something like this. Also, when the gas content is relatively high in an abdomen, you can also think about that. In severe cases, when there is gas in the bowel wall, it shows like this. This is a small bowel with small villi, it was called. The villus are very small, but it reached the size of almost like a colon, right? Also, this patient that you have seen in the very last was a thoracic aortic dissection case. When we are looking at a case, I look at the pulmonary arteries. I'm not seeing any thrombus inside. This was also a pretty young patient. When I start to follow the aorta, the ascending aorta is fine, but when I go to descending aorta, the descending aorta is disproportionately big than the ascending one. It's much dilated, and there is a line which is simply supposed to be not there. So there is actually two lumens, not one, inside this blood vessel. This is a very important case also. The mortality is quite high. It can happen with any age, especially with young generation, which has a syndromic appearance like Marfan, like very tall people, and in other cases like collagen vascular problems. Most of these patients are usually doesn't have a diagnosis before, so you have to be very cautious about detecting them, and thoracic CT with contrast is the only way that you can diagnose these patients. So the patients can have hypertension, and always look for the atypical face expressions like collagen vascular disorders or Marfan, tall statue, for example. And in case of vasculitis, for example, like Wegener this. And in case of aortic dissection, usually arterial tension difference between arms it can be diagnostic, but if the subclavian artery is not affected, for example, this kind of a thing doesn't happen. So when you measure the arterial difference and it's normal, like it doesn't exclude, unfortunately. So there is chest pain in these patients, and usually a tearing sensation, like a very severe pain with tearing sensation, can raise some question marks. Okay, so this is a case of pneumothorax. I include these patients like a very small thing of what's coming to you next for the next lectures. As you see, we are seeing the lung parenchyma here, but not seeing the lung parenchyma definitely here. So, and the lung is actually deflated and fallen down. So the lung parenchyma has fallen down here. And in this case, which is quite a minor, because I can see the lung parenchyma, the air is still present there, and there is only some minor amount of, volume loss. So the lung is actually here. So there's free air which has escaped to the thoracic cavity, and the lung didn't collapse yet. But looking at these two images, the one on the right is more in danger. Can you guess why? This one is in more critical condition. When I see the lung, I assume like nobody has an idea, right? Okay, I see the heart is right here, but when I look at this, the heart has gone to the mid-thorax actually, and the air volume of left hemithorax is significantly larger than the right hemithorax, maybe like this. So the air density is much, the volume is much higher in here than here. So when I compare, I can easily see, which is the case here, but it is not as severe. So what, can anybody guess what I'm trying to talk about here?
Is it the shifting? Because of shifting.
Yeah, it's like shifting, right? It's a shifting through that. So there's a name for this. There's a name for this. It's called tension pneumothorax. Tension pneumothorax is this one. When the air can get out to hemithorax but cannot go anywhere else, then it the hemithorax gets bigger and bigger. Then after a while, it starts to push the healthy lung to the side and depleting the respiratory capacity of the patient. So this is more dangerous. Tension pneumothorax is a very important case, very important one. It has a very easy cure, by the way. What can you do for the patient on the right?
Needle.
Yeah, needle, right? Just a small needle. Small needle can solve all the problems. Just pierce some needle and leave it there. Okay. Just don't do it perpendicularly so that it will stick the lung more, so it will make more pneumothorax. That do a little bit parallel to the wall. So make sure you have gone through the inner pleural layer. Then you can easily cure tension pneumothorax. Very good. Thank you. Okay. This was a case of tension pneumothorax. This was another case of pneumothorax. In your oral examination, there will be a lot of pneumothorax cases, believe me. So it's pretty hard to see here, but I think it's on the right side. Yeah, I used to be seeing it, but okay, I will not ask you anything that I will not see. Make sure of that. I'll make sure of that, don't worry. Let's pass this one. Okay. Anyway, this was another thing in your document. So my question in the document was what could be the examination finding in a testicular torsion patient? Like, you know the clinical of a testicular you know the clinical condition of a testicular torsion, but what can be the examination, physical examination finding? Does anybody know?
Like the Doppler, there is no blood vascular. There's no vascular.
Yeah, but you can't see it. I mean, like physical examination.
Yeah.
What can you see when you're looking at the patient?
Swallowing.
Yeah, swelling. True, but that can happen with infection as well. In infection, there can be swelling as well.
Severe pain.
Yeah, pain, but pain is symptom. Physical examination.
Cyanosis.
Cyanosis, maybe. Never seen that. I think it doesn't happen.
Yeah, almost.
When you know the pathology of the testicular torsion, right? Like the testis turns around itself, so it depletes the vascular flow, so it gets necrosis after a time. After this torsion, because it is torsionized, like it usually goes like 300 degrees, testis gets elevated. Okay, testis elevation is the finding in testicular torsion. When you look at the patient without touching the testis, the testis with torsion usually gets elevated. It can be a big point, but you can never exclude testicular torsion when there is no elevation. So in a case when you suspect testicular torsion, you always need to do radiological examination, okay, which is ultrasound, as you know. So how many hours does the patient have in a typical case of testicular torsion? Did you know this?
1 hour or half
6
hour.
hours.
6 hours is the right. Yeah, 5 to 6 hours is what you have. When you do the operation in 4 to 6 hours, you save the testis in 90% of the cases, which is relatively good. If you send the patient back home, if he sleeps over that, he cannot sleep over that anyway. But if after 12 hours, it's 50% necrosis. After 1 day, it's just 90% necrosis. One of my friends have a case like that. When he was working in the East, he just skips a case, like he misdiagnoses a case of testicular torsion and sends them back home, which goes to necrosis. And he definitely doesn't remember anything about it. Like he doesn't remember the kit and the examination or anything, because it is that busy in that emergency setting. So you need to make very strict decisions in a very limited amount of time under extreme pressure. So a lot of mistakes occur, like it's gonna occur anyway. But as long as, like, as much as you can save yourself from these mistakes, it's gonna be better for you. That's pretty much the hyper emergency radiology lecture was about. So you don't have a workaround for pneumonia here. You don't have any case for renal colic here. No hematuria. Nothing for right upper quadrant pain. There is nothing for bleeding, for example, because in a case of bleeding, you will be seeing the patient bleeding anyway. Like you cannot miss a case of gastrointestinal bleeding, for example. So I tried to make a brief emergency radiology lecture based on these hyper emergency cases that you can miss in your clinical practice. That's pretty much it for today, people. Thank you for attending. I didn't put an attendance obligation, but everybody's here. Like it's made me quite happy, actually. Thank you.